Welcome to the Healthcare Air Deep Dive Podcast. My name is Garth Holmes, and today we have Dr. Hudson Garrett joining us as we talk about moving the needle on making healthcare air safer. Now, before we get started, Dr. Garrett, could you tell us a bit about yourself and your experience in training in infection prevention?
Sure. So my name's Hudson Garrett. I'm a family nurse practitioner by background and training with a specialty in infectious disease and infection prevention. One of my deepest passions is interprofessional collaboration. I love to break silos. I think healthcare is full of them. And yet the complexities that we face, whether it's surgical site infections or things like hand hygiene, require interprofessional collaboration. And so I'm really honored to be deeply engaged with different organizations, whether it's infection prevention or surgical site infection work with AORN. I have the pleasure of serving as the current chair for the National Infection Prevention Task Force for AORN. I'm also on the AORN Journal Editorial Advisory Board, and also a member of the Guideline Advisory Board for AORN. That's important because I think it helps us cross the chasm, right? Because I'm not a perioperative nurse by background, but I deeply integrate in their work because I respect it. And I also value their perspective in the work that they do in reducing surgical site infections. I'm not afraid to cross the red line. And I think that infection preventionists have to have that approach of collaboration with our perioperative colleagues. And I think that's a really important perspective that we have to bring to the table as we target zero surgical site infections.
Thank you for sharing that, Dr. Garrett. With your experience with AORN and being on the Guideline Advisory Board, could you tell us more about the new guidelines that AORN has released related to healthcare air quality?
It's a great question. Many people may not be aware, but back in April of 2024, AORN, on its normal cadence of updating their guidelines, updated the sterile technique guideline. And in that guideline is actually a whole new section related to improving healthcare air quality in the perioperative space. And I think it's really important for our listeners to note that the perioperative space includes not just inpatient operating rooms, but really anywhere that procedures are performed. So it really follows the definition from CMS. So that would include things like interventional radiology, GI labs, any of those outpatient procedural areas, including ambulatory surgery. And so, what's really interesting about this guideline is the sterile technique guideline has always been, I think, one of the most fundamental ones that AORN has had. It's one that is instrumental in reducing surgical site infections. And so it's a logical fit for air quality to be sort of inserted there. But what it really does is talk about some of the new things that we can do on top of our existing SSI bundle to get to zero, because no patient comes into a healthcare facility, whether it's an inpatient or an outpatient facility, and says, I want a surgical site infection. They're coming in with the expectation of safe and perfect care. And now we can actually add another layer of safety that not just protects them, but actually also protects the staff members that are there to care for them as well.
Now, with the goal of targeting zero surgical site infections, what is the correlation between SSIs and air quality? Is there a correlation?
Well, if you asked me this question 10, 15 years ago, I think my answer would have been, I don't know. But having gone through a pandemic, looking at the new literature base that's out there in the peer-reviewed literature, we can now start to directly correlate poor air quality with increased risk for surgical site infection, and not just surgical site infection, but also increased occupational risk for our healthcare team members that are there caring for patients during their perioperative experience. And so that's our nurses, our technicians, our physicians, our anesthesiologists and anesthesia personnel, as well as the other individuals that are there as part of our interprofessional care team. Surgical site infections are complex. Patients are complex. And what's really challenging for us is that there are many things that we cannot control, the comorbidities. For example, if a patient is a uncontrolled diabetic, we don't have a lot of control over that. If they're morbidly obese, we can't control that. But we can control things like the temperature of the patient. We can control, hopefully, their glucose during the surgery. We can make sure that the environment that we have for the patient is as controlled as possible. We can clip and not shave. We can make sure that the patient is properly positioned. We can give them the prophylactic antibiotics. Well, now what we're doing is saying, well, what else can we tag on top of that to reduce the risk for surgical site infections? And what's unique about air is it's very similar to water. It's one of those environmental risk factors that we're all exposed to. And I think what's challenging is that, think about when you go to the dentist. You're sitting there in the chair, you're getting your twice a year teeth cleaning, and you can look up and you can see what's in the air because you can see the aerosols. Some of them sometimes may be tinged with blood, as an example, because maybe they're doing a procedure. Well, our challenge in the perioperative environment is, with very few exceptions, we can't see the risk in the air. So I don't know the bacteria, the viruses, I don't know the VOCs, I don't know the carcinogens that might be aerosolized. And so it's truly an invisible risk. And that's really what we have to prove out even further is how do we decrease that risk with surgical site infections and tie it more closely to air quality improvement. There's a lot of literature out there that has demonstrated this, whether it's volatile organic compounds, some of the bacteria and the viruses, the bloodborne pathogens that we have to be concerned with from an OSHA perspective. And I really commend AORN for being the first ones out there in the peer-reviewed space that have said, this is a direct causal link that we need to start to consider. And this is not just a call to action for perioperative clinicians, but it's also a call to action for our infection preventionists, right? And I think that's a really important interprofessional collaboration that we have to build.
Dr. Garrett, you talked about the importance of air quality and this call to action. Now, who should be engaged in this effort to improve healthcare air quality?
Well, air quality takes a team. And, it certainly starts with the infection preventionist and the perioperative nurse leader. So that's going to be certainly our core and foundational team. But think about building services and engineering. They are core partners in this. They're the ones that are maintaining the HVAC system to ensure that it's working properly. And, I live here in Georgia, for example. Now it's March when we're recording this, but as soon as we get to May or June or July or certainly August, it's going to be sweltering hot. And so the environmental sort of impacts of the HVAC system are going to change with those environmental challenges from the outside, the humidity, the temperature. When it rains, for example, that's going to impact the functionality of even the best designed HVAC systems. And so they may not be optimized to perform. And so we need building services. We need infection prevention to really lead the data collection, the analysis, and really correlating back where the SSIs are coming from. They need to sort of hold the data along with their healthcare quality colleagues. Our perioperative nursing colleagues are the ones that help us dive deep into the teams, the service lines, the procedural areas, what may be going on, the equipment that's there. And I think our healthcare quality personnel are a new sort of team member to the equation because they are the masters at data. They hold a lot of the data, they publicly report some of this data, and they are tremendous partners in analyzing risk along with their healthcare risk managers. And I think the last person we have to absolutely consider is our patient. Our patient is our consumer. They're the sort of core foundational person that we're there to serve. Without our patients, we don't have a job. And I really fundamentally believe we need to actively engage them in the process too, and let them know proactively what we're doing, not only to improve the healthcare air quality in their experience while they're with us, but also the fundamental elements that we're doing to reduce surgical site infections and what their responsibilities are, whether that starts from the preoperative experience before they ever get there, all the way through the postoperative experience once they get done with the procedure.
So, since we're all breathing in air, is the air quality only an issue that impacts patients, or is this also a big issue that impacts healthcare staff?
Think about when you're at your own home and you go to get a glass of water. You have an expectation that your municipal water is safe, right? That the city or the municipality that treats your water makes it completely safe for you to drink without any restrictions. And you go and you put that in your mouth and you then put it in your body. And we have seen over and over again, whether you live in the biggest city or the smallest city, that there can be risk associated with that when things are not done correctly. The same could be absolutely true with their HVAC systems. We're reliant upon potentially an outside contractor to come in and optimize and maintain these systems in our largest hospitals and even our ASCs. And so, air is something that impacts our patients, our visitors, as well as our staff members. And while our patients are with us for a very finite amount of time during their procedural sort of experience, our staff members are with us for many hours during the week. And so I would encourage us to think about sort of both sides of the equation. What are we exposing our patients to during their procedural journey with us? But more importantly, is what are we exposing our staff members to? Our staff members are overly reliant upon personal protective equipment, particularly mask. And we know that mask on sort of the schedule of interventions, our triangle of interventions, are at the very bottom as far as our efficacy. And it's not to say that PPE is not important. It certainly is. And we know that our perioperative colleagues are really the most efficient and I would say the most judicious about using PPE. But that's one line of defense, and it's really the last line of defense. What we have to be more careful about is what are the multiple modalities in protecting them from airborne contaminants? Think about an orthopedic procedure where maybe you've got bone cements, you've got VOCs, you've got potential issues that are going up into the air. Well, I may inhale that. Do I have some type of point of care solution that allows me to remove those potential chemicals, in some cases, carcinogens and other VOCs that might cause me harm? And I think the best work has been done by NIOSH. And most healthcare clinicians have never heard of NIOSH. It's sort of this hidden entity within CDC that does tremendous work on looking at occupational exposure. They also provide guidance to OSHA around things like respiratory protection. They were huge during the COVID pandemic with providing guidance on the proper use of N95s. And so I really commend them for their small shop, but very mighty shop of output that they look at, protecting us. And here's the thing is that we can have, thousands and thousands of patients, but you have to have a correlating number of thousands and thousands of experienced perioperative clinicians to care for those patients. And so I always go back to we need to protect our staff members and our healthcare workers just as much as our patients. And so healthcare air quality impacts both.
Now, Dr. Garrett, you've been talking about the importance of air quality, who should be involved in improving it. But thinking from a management perspective, how should healthcare air quality be managed?
Most people have to start with a program. And, I think that can be a daunting and overwhelming task. And, anytime you say develop something new, develop a new program, most people run for the hills, and rightfully so. I can appreciate that perspective because, developing something new in healthcare when you've got 5,000 other things that are important on your plate, that's scary. Right. And so the good news is that there are, sort of some alignments with nonprofits like the International Respiratory Infection Society, where you can participate with more of a collegial and collaborative and consultative approach to have a program developed that you can customize for your facility, whether again, a hospital or an ambulatory surgery center, to help guide that pathway with, meeting all the different regulatory and accreditation requirements. So if you're Joint Commission, DNV, or AAAHC, I would encourage you to check out that program available through IRIS. It's a great starting point that removes sort of that barrier of entry. So first and foremost, you need to develop a program. Secondly, you need to have the right people that are engaged in the process. Healthcare requires alliances, interprofessional relationships, and accountability. And we are great at forming committees in healthcare. I think, those that are listening to this now are probably laughing at this point saying, yes, we're awesome at forming committees. What we're not so great at is actually developing and holding each other accountable. And so what I always encourage people to do is don't form another committee if the committee's not going to have teeth, right? Because we don't want to form a committee that's not going to be able to accomplish our stated goal. And our stated goal has got to be something that we share. And hopefully that goal is to get to zero patient harm, zero staff harm, and zero surgical site infections. Because no patient comes to our facility and signs the informed consent and says, please add a surgical site infection. They all come to us and say, I'm not well, I want to get better, and I entrust you with my health. And they're putting that most vulnerable moment that they have during that surgical procedure in our hands. And that's a tremendous responsibility. And healthcare air quality is something that impacts them, it impacts us, and it impacts our environment. And so I would start with that shorter shared goal, that approach. And then lastly is, what are you doing to move the needle and keep it moving in the sort of the direction, should I say, of zero? And that's where data analytics and sort of accountability come in. And you may try something and it doesn't work, and that's okay. What's not okay is not to learn from it. And so failures that are turned into opportunities for learning, those are fantastic. As a matter of fact, I think back to all the times that I've fallen on my face, and I've turned them into opportunities for learning. And I've fallen a lot. And each of those times I thought, what can I learn from this experience? How can I translate it into a positive? And how can I make sure I don't make that mistake again? And that's the attitude we have to have. And the good news is that there's a lot of colleagues out there that are doing good work, and we can network and we can liaise with them and learn from those best practices as well. And using data to manage our expectations and sort of where we're going is helpful. The challenge that I always face is most data, especially with SSIs and air quality and infection control in general, is retrospective. It's 30 days after the patient's discharge. It's presented at an infection control committee. What we need more of is real-time data access where I can go and immediately intervene, hopefully say, wait a minute, we have a problem in OR number 4. Maybe it's service line related, maybe it's surgical related, maybe it's procedure related. And now I have the opportunity to directly intervene and stop the harm from occurring.
Thank you for mapping that out. Now, specifically thinking about air disinfection technologies, how do they fit into a bundled approach for reducing surgical site infections?
Yeah, so I mean, I think it really depends on how you look at your bundle, right? And so most people right now are using a what they call a functional HVAC system. And again, I go back to how functional is your system? If you're in Arizona where you have no humidity, but you have high temperatures versus in Georgia where you have high temperatures and high humidity, our performance is going to be different. And I think that's an important element to consider as environmental factors are going to matter. Let's look at California. Our colleagues in California have experienced for years challenges with wildfires. So their fresh intake of air is going to be super challenging, right, to accomplish. And so I want to make sure I can stack the deck in my favor for SSI prevention. And we have a very well-established bundle, things like our prophylactic antibiotics. You may, do things like, patient bathing before, depending upon the procedure. We're going to make sure that we clip and not shave. So there's some basic elements of things that we certainly are going to do routinely. But what we have to make sure that we manage as much as possible is situations we can control. And I think that's an important element is how do we make sure we control those elements when we can? And that's the more challenging situation for healthcare facilities is that if it's under our jurisdiction, what are we doing to influence it? So if the OR, for example, is too cold, we know that that can cause hyperperfusion in our patients. Hyperperfusion leads to decreased healing time. Decreased healing time, bad outcomes, right? And so the same is true with air quality. If I can maximize air quality at sort of the point of care where the procedure is performed, well, maybe I'm going to reduce the amount of potential pathogens that might go into the patient's surgical field, as an example. And that's part of that broader bundle. And there's a lot of, I think, adjunctive technologies that have been thrown around in the space. There's UV robots for surface disinfection. There's FAR UV that is being deployed up in the HVAC system. And each of these technologies is interesting and I think has, a conversation to be had. What I think is challenging is point of care. And so one of the things that I really like in both the AORN guidelines as well as the new pending CDC guidance that's coming out from HICPAC is how do we bring it to the patient's bedside? How do we make sure that when we're doing something to reduce surgical site infections from an air quality perspective, we're able to do it as close to the patient, right? The risk factor as humanly possible and drive those results home. And that's where we get a lot more control over our outcomes. And as an infection prevention expert, I want to make sure I can drive the outcome towards zero as much as possible.
That's great. Now, thank you, Dr. Garrett, for joining us on the podcast today and for sharing so many valuable insights as together we move the needle forward on making healthcare air safer.
It's my pleasure. It's an important topic, and I hope it's one that's helpful for our perioperative infection prevention and our other stakeholders in this important dialogue.